This is Keith of Keith RN, and I want to welcome you to our monthly Facebook Live. The school year has begun in earnest for most of us in nursing education. I hope you're doing well. I hope that as you look at the new year, even though there's a lot of challenges, struggles, I hope that you see the difference that each of you are making as we really, begin to embrace the paradigm of preparing our graduates for real world practice. And if we haven't met, my name is Keith, and I founded Keith RN 13 years ago as just an everyday, passionate nurse educator. Brought my lens of clinical practice to, again, strengthen and just, how we teach nursing so that the realities of clinical practice through unfolding case studies and other resources are apparent. And, we want to change the way we think in nursing education. The culture is oftentimes NCLEX oriented. It's a little bit kind of like the Matrix. It's an invisible kind of thing that just recognizes that we struggle to really put first things first, which is preparing our graduates for real world practice. And that's been my passion, is preparing educators and equipping them with tools, case studies, and other practice-based strategies to prepare how our students are taught. So I want to thank you for joining me tonight. I also want to share that, Katrina, you're the first one here. Thank you for jumping in. And RN's in the house, says Lee, and Betty, thank you for joining us. If you're here, we have a great attendance tonight. We're going to have a really exciting topic as we talk about the NCLEX going online and what really matters for nurse educators. And what we're going to be talking about with Maria and myself, Maria's our nurse educator consultant with Keith RN. We're really going to be saying, the NCLEX is important, but yet what can we do differently to make the NCLEX not the format, make it just what it is, a test. What can we do differently to strengthen practice readiness of our students? And what does that look like? And what are some strategies and ways we can do that? I want you to know that we're going to be talking about a new teaching framework that I've developed over the summer based on Tanner's clinical judgment model called the 6 R's of clinical reasoning. We just redesigned our website and we put a brand new space on Keith RN. So if you haven't visited KeithRN.com. I just put the link in the chat. We have a brand new opt-in. We've got an incredible teaching resource called the 6 R's of Clinical Reasoning. We'll talk about towards the end of our discussion because we're going to talk about some first things first. And so I just want to thank all of you for making this a part of your Thursday evening, and want you to know that we have these every month. And we have Keith RN has a Facebook page, or a YouTube channel, Think Like a Nurse, that we have these Facebook Lives since I began doing these about 3-4 years ago. Plus, I've got hundreds of other little blogs or articles and YouTubes that I've done over the years that are great for students, great for educators. And I've got some really helpful content on that. So you can get our past lives. We talked about at-risk students in nursing education last month. And this month, we're going to basically be talking about the NCLEX going live. And I want you to know that the NCLEX going online and what matters for nurse educators. And to prepare you for this conversation, I'm going to bring Maria, our nurse educator consultant, and basically share the blog that she wrote for us last week on this very topic. So if you want to kind of get a head start and look at kind of where this crucial conversation is about the NCLEX going online. Is that a good idea? And some of the highlights from the conference that the NCLEX had their annual conference just yesterday, Maria. So I'm going to bring you on and just we'll kind of let you take it from here and just give us an update, Maria, on kind of what some of the highlights from the NCLEX conference and where you'd like to go with our conversation tonight.
Sure. So hello, everyone. Thanks for joining us. I'm guessing that some of you that are here tonight may have been at the NCLEX conference yesterday. If you were, let us know in the chat, because I would love to hear what your takeaways were, and we'll talk about that in just a moment. The big news that came out before the conference was that the NCLEX is going to go remote in 2026. But what I found interesting is that NCSBN didn't really want to talk about it too much yesterday. They didn't really take questions on it. They addressed it in the beginning for a few minutes, basically saying this, that they have no date for when the NCLEX is going to go remote. And that's really all they had to say about it. So I don't know if you guys found that interesting. I kind of did, because that was the elephant in the room, if you will. But the elephant didn't really get addressed. And I do see Tanya Taylor was there, Carolyn Holden was there, and several of you attended the meeting. So I would love go ahead and tell me what your takeaways were from them. Really, I mean, did you think that they adequately addressed the subject, or what did you guys think? I'd love to hear you put that in the chat. But while I'm looking to see what people have to say about the NCLEX conference, I want to throw out a question to our general audience. What is your reaction to the NCLEX going remote? That's really how we want to start this conversation, because we posted a question on our Facebook group, and it has gotten, I think it's gotten almost 200 reactions and almost 100 comments to this point. It says it's reached almost 10,000 people. And the question was simply, if we built entire nursing programs around teaching to the test, what happens when the test itself is being questioned? It must have been a provocative question, because people had very strong responses to that question, which is good, we have passion. We're passionate about our profession, and we should be. So go ahead and tell me what you guys think about the NCLEX going remote. I'm sure I see the chat going, so we'll talk about some of your chats. I will say this, what I've heard so far, there's a lot of worry around cheating, and that's an awful thing for us to have to worry about in nursing, isn't it? But there is a lot of worry that the cheating will get worse with it being remote. There was one person in the Facebook group that said, why are we damaging our profession? I mean, people have very strong feelings about it. There are people, however, that think this is a good idea. It's going to increase availability of the test, especially for people that are in remote areas. So let me see. I want to go to the chat here and see. I'm seeing a lot of I'm concerned, not a fan of the idea. Cheryl says that she was at the conference and that they said more about remote proctoring last year, which is true. But I took that to mean that they are still evaluating it. Yeah, Cheryl, I wondered if maybe they've said they're going to do it, but maybe it's further down the road than we think. I don't know. Terrible idea, someone wrote. NCLEX at home is concerning without strict protection of the test, and that is just one facet. NCSBM was not wanting the topic on the agenda or a Q&A, made their blanket statement, and that was it. And that's true. That's what I took away too. So I'm getting from a lot of you that you're not liking the idea. Now, Abby says, I think the idea may be to remove barriers to taking the exam. I totally agree, Abby, but I think it's actually going to pose more barriers, because a lot of things are going to have to be in place for it to remain a secure exam. Yep. Okay. Cheryl, okay. Cheryl says it's, let me put this up. Cheryl says it's divisive to suggest teaching to the test is a sacrifice to teaching clinical judgment. They do not have to be one or the other. And that is true, Cheryl. That is true. I'll take that a step further, though, and say this. NCLEX itself, NCSBN themselves, said that they were not doing a good job before NGN in testing clinical judgment. They put it out there for the whole world to see. They're not putting anything out right now saying that they're doing a much better job. We hope they are. We feel like they probably are. But the concern that I have is that we have pass rates in the 90s, and they've been in the 80s and 90s forever. But clinical judgment, entry level clinical judgment, has continued to decline. So we don't have a correlation between high pass rates and clinical judgment. And why is that? I think it's because we've put the emphasis on the wrong thing. We have put the emphasis on NCLEX, and that doesn't necessarily mean that we're not teaching clinical judgment, but we put the emphasis on making our students better test takers instead of making them better nurses. And if we focus on practice readiness and that clinical judgment and getting them ready for practice, the NCLEX is going to come. We know that. If they're ready for practice, they can pass the NCLEX. So I wonder, when we do put all the focus on NCLEX, and you know what I'm going to say, I'm not going to wonder. When we put all the focus on NCLEX, we're not getting good results. We're already seeing that. I'm seeing, Keith, I'm seeing lots of chats, and I'm not able to look at them. But have you seen anything that we need to discuss here?
Yeah, no, it basically, I think it definitely is a very hot topic, Maria. And we're not going to, our goal is not to say don't do remote proctoring. It's going to, really we want to step back and recognize that, the importance of laying a different and a stronger foundation in nursing education that isn't built upon high stakes testing, but is built upon developing, like Nightingale valued, the character of the nurse, the values, the ethics, the integrity, the caring behaviors, as well as the immersing them in practice as much as we can, despite the limitations of our clinical settings. And how can we practice the thinking of practice in ways that are going to really prepare our students better for real world practice? Because again, if we put first things first, if we put practice readiness and strengthening their preparation for practice and the clinical judgment that's required, the multitasking skills of multiple patient assignments, etc. If we can practice that through salient unfolding case studies, the NCLEX and all that it represents will take care of itself. And we really want to just kind of recognize that the culture in nursing education has really put the NCLEX as the center, as the sun, and recognize that by doing so, we're opening ourselves up to these vulnerabilities, that the gap of how nursing is taught and practiced continues to be as wide as it's ever been after 50 years that it's been documented. And so change is needed in nursing education. And I think the bigger conversation, Maria, is how can we look at, basically, we don't want to de-emphasize the NCLEX, but we want to put it in its proper place, which is merely a multiple choice exam to validate minimal competency of entry into practice. And do we really want to have a bar that is minimal competency? Or do we want to have a bar that is like they are well prepared for practice, and minimal competency is something that we've addressed and is even, they are above and beyond minimal competency. Right. And that's why we're not seeing our students retained in the profession. We're seeing up to a third of our students dropping out of nursing entirely after 3 years, right, according to some studies. And so we need to recognize that our new nurses are not equipped for practice. We are part of that problem, but we are also part of the solution, Maria. And that's what I want us to focus on tonight, is that we got to pray the serenity prayer. There are things that we can control, and there are things we can't control. So we can't control what the NCSBN does. Right. Okay, they're going to do what they do in their tower, and what their decisions will be, we'll have to abide by at some level. But we can control how we teach. We can control how we prepare our students for practice. We can look at what clinical judgment models are we using to teach nursing and clinical judgment. Are we using a practice-informed model or a licensure exam model in using that same language to teach students when practice doesn't speak that language, and they're using Tanner's and Lassiter's rubric in practice to evaluate clinical judgment. And we are now going down a rabbit hole of using the NCSBN model in ways it was never intended to. And that's another conversation. But Maria, I want to let you just kind of throw some of your thoughts and comments.
No, I'll continue with that NCLEX is changing, but nursing education doesn't have to change. Well, maybe some parts of nursing education need to change, but our focus as nurse educators should have always been on practice readiness. And if it hasn't, I think we're seeing that it needs to be. Even NCSBN has brought in practice educators the past couple of years who have talked about what they've had to do to get new nurses ready. And so what I want to say is that the NCLEX may be changing. It may get questioned. The validity of the test may be questioned, but that doesn't change our focus, and it shouldn't change us. We are readying nurses to take care of patients and to take care of patients safely. And the way to do that really is to bridge that gap and to teach nursing the way we practice nursing. And if you guys that were there yesterday, what did you hear the practice educator, the ER nurse, talk about? All she talked about was Lassiter's, right? Lassiter's, that's based on Tanner's clinical judgment model. And so they're using Tanner's and Lassiter's in practice because it is the language of practice. And I don't know why we wouldn't do that in our educational settings, why we wouldn't use Lassiter's and Tanner's and use the language of practice versus cues and hypotheses. I've been a nurse for over 30 years. I've never walked down the halls of a hospital and said, let me go prioritize my hypotheses for my patient. It's just not language we use. So why are we using that language with our students? And again, the model was written, it's a measurement model. It was written to write test questions and measure test questions. We as educators need to know about it, and we need to know how to use it to write test questions. Do our students really need to know that? I'll leave that up to you, but my answer is no. So I think when we think about solutions, we need to think about practice, and we need to think about using a model that is practice informed. We need to start thinking about really teaching the way that we practice. And that means we don't need NANDA. We don't need 30-page care plans. I had this conversation twice today. I talked to two people who wanted to learn more about our Think Like a Nurse membership. And they said, one person in particular said, we're drowning with 20 and 30-page care plans. And I just looked at her. I didn't say anything. She said, why are we doing that? I said, I wanted to ask you that, but I didn't want to be rude. She said, why we're doing it. She said, and we're doing nursing diagnoses, and we don't use nursing diagnoses in practice. She gets it. She sees that we're doing something wrong in our programs, and she wanted to change that. So my thing is, yes, let's get solution oriented. And the way to do that, we're all practitioners here. Most of us probably were expert practitioners who became educators. Let's get back to that practice mindset, and let's start teaching the way that we practice. Let's start using those frameworks that they're using in practice, that NCSBN even showed us they're using in practice.
Let me just share a quick illustration that I just want to kind of, ATI, this is an illustration that ATI gave me permission to share that they developed, but I want you to recognize that we've got 3 clinical judgment models. And that if we focus on teaching Tanner's clinical judgment model, which again, its purpose was to identify how do nurses think in practice? What are the thinking processes that nurses use in practice? Almost 200 articles that Chris Tanner filtered through to identify these 4 processes of noticing, interpreting, responding, reflecting. The nursing process also aligns with Tanner's in the middle center. And by the way, if we teach Tanner's and the language of practice, and we teach a practice-informed framework, The NCSBN model aligns with each step of Tanner's of recognizing cues and noticing, etc. And what I want us to really if there's one paradigm shift, I think, in nursing education that I would love to see each one of you grab this bull by the horns with is really simple, is basically, because our focus in nursing education is to prepare our students for practice, not to pass a test. Let's be very clear about that. Let's make that our primary purpose and a mission statement. We prepare graduates for real world practice in XYZ nursing program. Let's make that our passion and our focus, and we teach a practice-informed framework of clinical judgment in the curriculum as a theoretical model. And then, by the way, in the final semester, the final few weeks, we have our NCLEX prep, and we talk about we have our capstone, we have our NCLEX emphasis. Now we mention the NGN model. In that final preparation for NCLEX, saying, oh, by the way, we've taught you Tanner's and the importance of noticing what's most important. The NGN model has a case study with 6 questions. And the first thing they're going to want to know is, what are the cues that you recognize? And basically show them how Tanner's and what you've already been immersed in aligns with the NGN model. And by the way, this is just simply to pass a multiple choice test called the NCLEX for your licensure, and you need to pass it. But let's just bring in the NGN model where it belongs as part of our NCLEX emphasis at the very end of the program, and then immerse ourselves with Tanner's in the language of practice and a practice-informed clinical judgment model. This is how we make peace with the NGN model, Maria, in my opinion. I don't know if that makes sense to you, but that's just my opinion, and I'm sticking to it.
Mm-hmm. No, absolutely. Absolutely. If anybody has comments or questions about that, you know what I would love to hear from the audience, what model are you using in your program for clinical judgment? And if you're not using a model, say you're not using a model, but I'd love for you to type in the chat what clinical judgment model or framework you're using in your programs. With that said, I want to kind of shift the conversation a little bit, still talking about the same thing, but I want to shift to integrity, because one of the big things, one of the big areas, topics that people are concerned about is the cheating, the academic misconduct, and that the validity of the NCLEX is going to be questioned if students are cheating. Now, I'm very familiar with proctoring, remote proctoring. I've seen some comments in the chat about students cheating with remote proctoring, and I think that brings up a lot of questions, right? How are they going to determine what cheating is? Who is going to determine that? When a student gets flagged for cheating, is that automatically that they don't pass the exam, or are they going to have to go through some sort of review process? I think it brings up tons of questions. I am loving that I am seeing Tanner's a lot in the chat. That's awesome. And I'm seeing Tanner's and CGM, which I see that a lot too. Nursing process is not going away, right, guys? I mean, we can't think about nursing without thinking about the nursing process. So,
yeah, the way we make peace, Maria, the nursing process is fundamental. It's kind of like the fundamental entry-level way of thinking. It's like that simple to complex. We start with nursing process, then we build on it with Tanner's.
Mm-hmm, absolutely.
That's the way that I've seen it.
What I wanted to, in talking with the integrity piece, is I would like to ask the question. I'm going to stick it in the chat too, but I want to ask this question of the audience, because we get very excited about academic misconduct, as we should. But my question to you is, what are you doing in your nursing programs to promote integrity? Are we purposeful with promoting integrity? Do we talk about it more than just to say, here's your integrity statement, sign it and give it back to me? Do we talk about how important integrity is? Do we talk about the fact that it is a foundational value in nursing? Do we talk about the fact that integrity is foundational to all that we do as nurses? If we don't have integrity, we have nothing. What are we if we don't have integrity? Do we really get students to understand that? Do we allow them the opportunity to ask questions about cheating and how we define cheating, what our expectations are? Do we really do that? And somebody says, I love it. Two people in professional identity. I love it. I didn't want to use that word. I wanted to see if that was going to come up from the audience, and I love it. Thank you, Amber. Thank you, Tanya. Hey, Amber. I didn't know. I saw your name. It's good to see you. Encouraging professional identity. Are we talking about professional identity in our programs? I'm gonna leave this alone. I can get it on. Anybody that knows me knows that I get it on a soapbox when it comes to academic integrity. But this is what I want to say. Nursing is more than just about knowledge and clinical judgment. It's about ethics and values. It's about professional comportment, and it's about leadership skills. Those are the 4 pillars of professional identity. And we should be covering all 4 pillars in our programs. And speaking from experience, I worked in a program that had cheating issues. And once we developed a rapport with our students and talked about the importance of integrity and valued learning over performance, in other words, everything was not high stakes. Everything did not have to be graded. You weren't going to fail an exam and then fail the course. We had formative assessment. We valued learning over performance. And we developed a rapport and talked about how important it is that you have to learn this. As a nurse, you can't cheat your way through nursing school and expect to pass NCLEX and go take care of patients. You have to know this. You have to develop your clinical reasoning skills and your clinical judgment in order to safely take care of a patient. We're not talking about going and running a machine on an assembly line. We're talking about taking care of a person. When I talk to students about that over and over, we didn't have cheating issues. You're always going to have that student that may do it. But my point is this: let's take some of the onus. Let's be solution oriented, and let's say we need to talk about this, because if NCLEX does go remote, again, I point the finger back at me. My job as a nurse educator becomes even that much more important. I've got to be ready. I've got to be sure that my students are practice ready. I've got to be sure that they know what integrity means. And that, to me, it's even more important now than it ever was. Our jobs are even more important now than they ever were if we're going to question that NCLEX, that exam. So I'll leave it there. Again, I'm going to let Keith. I know, Keith, you wanted to move on to a different topic. I want to look at some of the.
This is important. We're not going to go too quickly, Maria. Okay. We still have plenty of time. One of the things I also wanted to share, and I would kind of build on your question, Maria, and I would love some feedback from the chat. As people share that, this is what we do. I really want to get practical so we can look at looking at professional identity, defining it, because the essence of professional identity, according to Nelda Godfrey and the work that she's done with the International Society of Professional Identity in Nursing, they've got a wonderful website. I did put that in the chat. Be sure to check that out and get that on your radar. Get what they're doing there. They're on this path that is needed. And that emphasis, but in essence, we need to remember that, the essence of professional identity is that ability of that nurse forming their identity as somebody that is new. It's like medicine does a very nice job of this. They take a resident, and over the course of that residency, which they get a long time, they get 3+ years, they are formed into what it means to be a doctor, a physician. Now you're no longer a med student, you are a physician. And this is how you roll. In nursing, our students are just as messy as med students. They don't know what it means to be a nurse. They don't know what it means to care like a nurse, to think like a nurse, and to act like a nurse, as well as care like a nurse. And really, we need to recognize that our primary role as nurse educators is to enculturate them into the values of our profession, that again, like you said, Maria, integrity. If we don't have integrity, it's like, why are they, it's like if we are forming the professional identity as a nurse from day one in our programs, and we follow through with our academic integrity and plagiarism and cheating, we shouldn't even have to worry about the NCLEX proctoring going remote. It's like our students have that sense of what it means to be the few, the proud, the professional nurse. And they embody that, they live it, and they embrace it. And therefore, it's like, what are we worried about?
Right.
It's because we're not doing that, if we're honest. Our students do not have the integrity. We don't expect it. And we allow it to, we tolerate a level of plagiarism with GPT. We don't even, how much are we fighting it anymore? I don't know. It depends on the program. I mean, that's a very much program by program and leadership by leadership issue. But
well, you open the door to GPT, and I actually want to talk about that in just a second. But I want to put Dawn's statement here, because Dawn, I love this, and I think it's worth people seeing this, that we have a school theme every year, and professional identity was our theme last academic year. We do activities related to the theme at least twice throughout each course, as well as in the school committees that have student representatives. And it was pretty impactful, was the last sentence there that you don't see. Dawn, thank you for sharing that. That is exactly what I was talking about. You saw the importance of professional identity, and you were going to do more than just mention it and move on. You actually made it a theme. You talked about it in every course over and over, and you made it important. And that's what we have to do with our ethics and our values, and professional identity in general, is we've got to talk about it. We've got to make it important. We have to speak to it more than once. And I will say this, you guys probably know, if you know anything about Keith RN, that we have case studies, and we love to teach with case studies. Well, when you think about professional identity, it's not just clinical judgment, it's ethics and values, professional comportment. We have case studies on ethics and values, professional comportment. My point here being, use case studies to teach those other pillars of professional identity as well. There are things like human trafficking. That is a hot topic. It is a sad topic, but it is a hot topic. It is happening all around us. Almost 80% of victims of human trafficking come through the healthcare system. Think about that. And we don't talk about it in nursing school. It's not tested on NCLEX.
Yeah,
but we need to be talking about it. And the best way to immerse your students in it is with a case study, because they may not be able to get that opportunity in nursing school. Well, how do we give them the opportunity to know the signs and symptoms so that they're able to identify a victim and help that victim and know what to do to that victim? We put them in a case study. We immerse them in that situation in nursing school. Sorry, Keith, go ahead.
Yeah, no, I'm just going to share a link. I did a blog, and there is a nurse educator who is doing some groundbreaking work, Francine Bononeri, that I want to encourage all of you as educators. She wrote this guest blog a couple of years ago, and it's still very relevant. But the thing that Francine mentioned is that, is that if we can, human trafficking is an example. It's not in the NCSBN test plan for the NCLEX. Therefore, it doesn't get taught. And she did a study. There's over like 98% of nursing programs did not even address human trafficking because it likely isn't on the NCLEX test plan. And this is where we need to, again, as nursing education, we need to step back and say, what are we doing allowing the NCLEX to drive everything we do? And we've got practice-informed issues like human trafficking and noticing. And there are things that we need to notice as nurses that you can tie into your nursing assessment in semester one. Like if a woman has tattoos of dollar signs or profanity like F-U, that's the way traffickers brand many of their victims. And if there's somebody who's inappropriate, who looks like, yeah, they really don't seem to care about this person, and they're not a parent, and they're not, it's like there's just that seems off, but you don't know what to do. there's some things that we need to recognize and notice about human trafficking that nurses can make a difference. And this is where we need to, again, recognize our over-reliance on the NCSBN and the NCLEX test plan to inform our curriculum is a weakness in nursing education, but let's make it a strength. Let's not continue down this path. Let's make adjustments, Maria.
Absolutely.
And let's look at ways that we can make, so it's like, even when we look at, like when you talk about professional identity or caring and emphasizing caring behaviors and empathy, do you have some thoughts on how we can just make that more practical and how we can really kind of, when we look at these big themes of professional identity and nursing, well, here's a practical way to really improve what we do with noticing human trafficking is we just need to teach it and teach some very simple things. And then Francine has some case studies on her website that you can access, I think, at minimal to no cost on human trafficking. I happen to have a case study that I wrote with her that's in our membership. But the bottom line is that, there's some resources out there that I just want us to be aware of and to make a difference, because and just change the way we teach. That's the thing I want us to recognize, is that we can all make a difference by simply changing the way we teach. And I did see a comment. I'm going to put Francine's website on Nurses United Against Human Trafficking. So I'll just put Nurses United in the chat and send that out to you all. But the bottom line is that there was a comment that was present about, clinical sites are shrinking. We're not getting how do we prepare for practice? And one of the things that I really want to encourage you as educators is that when you use authentic, unfolding case studies that use open-ended questions, not multiple choice, because no patient has a multiple choice or a 3-column matrix that you choose from. Whenever we use case-based learning that has multiple choice items, even the NGN, it's preparing them to pass a test. We have to have the open-ended thinking of practice, and case studies that replicate the open-ended thinking of practice are essential. So our classrooms, Maria, need to be a practice learning lab where we are bringing context to our content. And that's what Patricia Benner said 15 years ago. Educating nurses, we need to contextualize our content to the bedside. And what does that? And even Benner was advocating unfolding case studies. Lisa Day, one of the co-authors, doing some phenomenal work with that. I learned from Lisa and kind of took my own lens of practice. And I think that as we look at AI, Maria, and you mentioned that, it's like when I wrote my case studies, and I continue to do so, they are authentic scenarios. They're not AI generated. An AI generated case study is not going to be something that is going to be nearly as effective as your own lens of practice with your stories and your scenarios. But we got to recognize the limitations of AI, and even some of the things that we're relying on it to do. We need to be very careful because of the accuracy and other things. I don't know if you have some thoughts on that, Maria.
Well, I for those of you that were in the meeting yesterday, you heard this, so it won't be news to you. But one of the presenters, she was the director of innovation and teaching, I believe, at NCSBN, said that, use open AI and create a case study in a few minutes. And there was no warning there. I think later she finally said, well, you want to be sure that you look at it and make sure that it's right. But I believe in AI. I use AI. But I also know that everything that AI, especially open AI. So open AI means that it's just using the internet. It's using open resources. It can't get behind any locked doors, anything that has got a password to get into. And of course, most of our resources that are vetted, that are valid, are behind locked door. So using open AI to create anything, honestly, test questions, anything, you still need to check the validity, the accuracy of that. And I feel that's important to say that. Also, consistency. can you use the same framework and the same framework of questions? Are you really using clinical judgment questions, or is it just a bunch of different Socratic questioning that's all over the place when you use AI for a case study? So there's just so many things to consider. And I wanted to mention that because you mentioned AI and it made me think of that comment yesterday. I cringed. It hurt me that she just very nonchalantly said, use open AI and do it in a few minutes and be done. If that's the attitude that we have, what are we role modeling for our students? We get so upset when students use AI. Well, if we're using AI and we're not vetting anything, our students are going to do the same. And we role model that behavior. I wanted to bring up a chat, Keith, before we move on. It's from Aubrey Marie, and it's long, but it's good. Aubrey,
Maybe we'll just kind of I'll let you read it, Maria, but that's the introduction.
But Aubrey says unpopular opinion, which Aubrey, I don't think it probably is an unpopular opinion. But Aubrey says you don't see residents, she's talking about medical residents, doing things outside of their normal doctor scope. What I mean is the resident is not coming down to give meds, but we take students to clinical for their whole nursing school life and expect that they perform all of the aid task. The facility expects it to and often relies on us to fill in when they are short staffed. And we focus on med pass every week, something that they will likely be taking over by med nurses or LPNs or med techs in the future. We are making them task-oriented and clinical, but expecting they are clinically competent. But we are not allowed to discuss patients and round like the residents. Sure, patient care first, clinical in terms of BAS, etc. But we need time to help them critically think about the whole patient, meds, labs, etc. Just like residents, because we are many times, and this is so true, expected to direct the residents and doctors with their orders. Aubrey, thank you for saying that, because Keith, I think this just, I'm going to let you respond to this, because we've talked about the classroom and using case studies in the classroom, but we have problems in clinical too.
Yeah. And we need to basically, again, make, one of the paradigm shifts that even Dr. Benner talked about in educating nurses, Maria, is that we need to bring clinical context to our classrooms, but then we need to bring we need to bring the classroom into our clinical and helping our students to see the importance of the knowledge compartment of understanding pathophysiology and how that impacts understanding medications, mechanism of action, lab values. Why is the creatinine elevated? Why is the potassium going up with this patient in acute renal failure, with heart, with heart failure, etc. And so, we've got to basically recognize that we can practice and develop that thinking using salient unfolding case studies. And I agree that they're not the end all, but yet in our classroom, we must do something differently than regurgitating a textbook and giving them all the information to pass the next test, which is what they want, but it's not what a student needs, Maria. And so what I just recently, with our, I have a brand new case study I'm sharing with our audience. I just put in the chat on sepsis. It's a urosepsis case study that I recently updated that came right from my lens of practice in the emergency room of a UTI going south, going into sepsis, into septic shock in an elderly female. So again, it's just a real authentic scenario using Tanner's framework, operationalizing it with open-ended questions with a link to breath sounds, heart tones, images of assessment that need to be recognized and noticed. And it's, again, all open-ended questions, lab values, then the thinking of the reasoning. And so we're not going to go over it, but I just want you to know that that is an example of the resources that we offer educators to, again, help practice the thinking of practice in everything we do, Maria. And I think as educators, let's just embrace that paradigm shift that we're preparing for practice. Therefore, we need to practice the thinking, not just give them the information, but let's show them how to use the knowledge. In a good case study in small groups, you've got, there's some, it's a powerful pedagogy. It's one of the best practices that we have to, again, teach a practice-based profession. And so.
And And I want you to continue on. And Nicolette, I appreciate what she wrote. She wrote that she does roundtable discussions in clinical and post-conference, and that gives them time to discuss and develop their critical thinking and clinical reasoning skills and really get, she uses the word deeper thinking and going deeper into topics. And that kind of leads us to how we want to finish out talking about this, because again, what our focus was for tonight was to talk about the NCLEX and it going remote and how you feel about that, and then bringing it back to solutions. And what I feel about the NCLEX going remote, I don't get that excited about it, because I think it just reinforces that what we do in our classrooms, our clinicals, our simulation labs is just that much more important. And so how we strengthen clinical judgment in our programs becomes even more important. And so we wanted to provide you with some solutions to help you strengthen that clinical reasoning. And Nicolette, when you said roundtable discussions and really getting into the deep thinking, it made me think about this framework we're just about to share with you, because it is a great framework to use in post-conference or debriefing. So for any of you that are, clinical instructors, even simulation instructors, and of course, even in the classroom, this is a framework that just makes the clinical judgment model more visible, easier to remember, easier for your students. And so Keith is going to introduce it to you, and we'll put it, I think,
Yeah.
we have a link that we'll drop in the chat too. So
Yeah, so what I've got here, Maria, I've got a couple links I just popped in the chat that I'm going to use. And I also have an illustration, and it's called the 6 R's of Clinical Reasoning. And it's 6 steps that all begin with the letter R. And it operationalizes Tanner's clinical judgment model so that it basically makes it easier to remember, but also adds an important step that's not currently included in the way that clinical judgment is typically taught, but yet it's also captures how a nurse in practice thinks. And so I've got a blog and video that's kind of got a nice combination of this strategy that you can download the free educator guide from either the website on the homepage or through this blog. It's also, there's a link there. So I encourage all of you to check it out and just learn more. But let me share, Maria, just kind of the illustration to just kind of set the table. And let me just pull this. I'll just kind of put it on the screen here. And really what it does is that if we know that, those of you that are familiar with Tanner's clinical judgment model and the first step of noticing, the first R of clinical reasoning that we want to really use this as kind of like a teaching framework. It's nothing new. It's Tanner's framework plus 1. And I'm going to explain that in just a moment. The first step of clinical reasoning to get to the outcome of a clinical judgment, according to Tanner's framework, is what do you notice? What do you notice that's most important or relevant? I made that into an R, and I said recognize what's relevant in your assessment. And so what I did is I made noticing, not just noticing, but I made it an R word that starts with R so our students can say, what did you recognize that was relevant? The second step of interpreting, really the essence of interpreting from Tanner's framework, it's really kind of a 2-step process, Maria. The first thing you need to do is interpret what it means, interpret what the relevant data is stating, but then what are the relationships to this data? How does this creatinine relate to the potassium being high? How does the elevated heart rate align with the elevated temperature? And what is the relationship of clinical data? That's what we do in a good concept map. But that really is the essence of interpreting, is relationships recognized. And so we want our students to basically step by step recognize what's relevant, identify or recognize the relationships, and then they begin to generate the responses of what's my priority, what's my nursing priority, how will I now, the third R, respond. I respond to the current priority. But now, once we respond to the current priority, There's really a 2 steps, Maria, that we use in practice. And that is basically, as an ERICU nurse, you're always thinking about what could go south here. What are the problems that could be that could develop in this patient? They're here for heart failure. They're currently stable, or they're currently post-op. Day one, but what can go south? They can develop a PE, they could develop a DVT, they could develop sepsis. So now we need to make visible that the current problem isn't always something that we have to keep on our radar. We have to also have a 2-step process to really strengthen failure to rescue. We need to identify the current priority, which is what the nursing process, what Tanner's does. But we also need to have the 4th R, which isn't really intentionally taught, except it's something that comes from my lens of practice and your lens as well: risks recognized. So what is the worst possible or most likely complication that could harm your patient? And Maria, I'll kind of share the side here. I used my Jason goalie mask. When I began speaking 13 years ago, many of you who've seen me speak at conferences, I said, what's your Jason? Because Jason is a killer who will kill your patient. But are you looking for him? Are you recognizing the risks that your patient is at risk for? They may not even have sepsis. But if they did, what would it look like? Why is their heart rate elevating? You see, this is where as a rapid response nurse, I have seen too many nurses miss this elevating trend of heart rate, blood pressure stable, but then it starts to soften, and then it goes in the toilet, and it's too late, and now they're dead. So we need to remember that to prepare our students for practice, we need to integrate this practice-informed step that after 30 plus years, that's just kind of how I practiced. We need to teach our students not just to respond to the current priority, but also the risks that are possible, and looking for that Jason. And so therefore, let's make risk recognition a priority in nursing education. And that's the 4th R. Then the other 2 R's of Tanner's are reevaluate the patient. So again, reflecting is what Tanner calls that. Reevaluate is reevaluating the patient. And then finally, we need to do the 6th R, which is reflect and refine your thinking. And so therefore, this is the limit. This is the shortcoming, Maria, of the NGN model in nursing education, that if we're using that practice-informed approach, I'm just trying to get this off my screen here so I can basically, there we go. As we look at, the reflecting on action, we reflect in action as the patient status and what the patient is doing. That's what the NGN model focuses on. That's what the nursing process focuses on. Tanner's adds a very important step called reflecting on your thinking or action. Was this the best decision made? What would you have done differently? What did you learn today? What would what did you learn that you can take into future practice with your next patient, and talk about that, debriefing that, reflecting on the judgments made is foundational to clinical judgment. And that's simply reflect and refine your thinking. So instead of using Tanner's language, which is more academic, I just kind of took Tanner's, made them into R's, added the risks recognized as a really key step that we want to make visible to our students, Maria, so that we are teaching problem recognition and anticipation, not just simply what's the current problem. Because if we look carefully at your NGN case studies and the things that we see that, when you look at that step of what, the responding or the, having that plan of action, it's always about the current priority based on what's currently showing. But there could be something brewing that isn't showing yet that may be 6 hours away, and you want to be looking for it. That's your Jason. What can harm or even kill your patient? And so let's bring risk recognition. I'll put them in the right way. Bring your Jason.
Nikki wrote in the chat, don't be a killer.
And we know, let's be honest, the dirty little secret in nursing education is that failure to rescue is a real thing. Look at these cases, these tragedies that are, that we all know about. These, that could have been prevented.
Josie
Yes,
King is an
those are just the
excellent
ones we
one.
know.
Yeah.
I mean, there's thousands of them,
Right.
and we know this as educators. We've seen it with our own eyes in
Right.
practice. We know of
Right.
colleagues, or even maybe our own error, that led to a bad outcome. Maybe not a death, but it led to a very bad outcome because we're human.
Yeah.
But my point is, Maria, is that by bringing risk recognition, using the 6 R's, I'm not out to make a name or to put, this is not a Keith RN framework. It's really just taking Tanner's, making it easy to remember for students. And I just want to get it out there. So you know what? This is something I kind of came up with over the summer that I just kind of thought about and want to just give a resource to educators to, again, help you bring practice-informed thinking. How can we make Tanner's more actionable? And remember, if we use Tanner's, Maria, the NGN will take care of itself because it aligns with Tanner's. It aligns. There's no inconsistency. But if we use even something like the 6 R's, we can make it easier to remember for our students. And I'll begin with R. Recognize relevance. What are the relationships identified? How will you respond? Risks recognize, etc. Reevaluate the patient and reflect and refine your thinking. It's easy to remember because they all start with R, and we all love a good mnemonic, do we not? And we use those because they work. They do make things easier to remember. And so my heart is for educators to see the value of this. And again, maybe, you see it differently, but I just want you to know that this is just something to put into your mix as another tool to strengthen and improve practice readiness. And again, if we can strengthen practice readiness, we not only will prepare our students, Maria, for a successful, lasting career in nursing and not just be a roadkill in 2 or 3. More importantly, our patients will have better outcomes and we can save a life. This is where a good nurse is a superhero, and it's a real thing. We can save a life because we were a thinking nurse that anticipated a potential problem. And so my heart was just to share kind of some of the practice-informed ways that a nurse thinks in practice that comes with experience or intuition. And again, our students are works in progress. A new nurse is a work in progress. It takes them 2 to 3 years to get competent and proficient. But I just, this is just a teaching tool I want to throw out there. We'll have an email sequence that follows. We've got some other resources to share. We also got a survey. We want your feedback. So we really want to know, because we could create case studies using the 6 R's. We could kind of just, in essence, how could we make this more easier to teach and strengthen practice readiness? And so I just, we wanted to close with just sharing the 6 R's and giving you, again, that opportunity to just simply download it. And it's a free opt-in. It's a free resource. We just want to share with you and make available, and more importantly, value your feedback. And you can email me. They come from me, so you can easily just reply to them. And I'll answer your questions or anything that you might have. And so with that, Maria, just and I'll just kind of,
yeah, I just want to say thanks to everyone. You've been very active in chat, and we appreciate obviously your engagement and all of the comments. I want to ask one last question as we wrap up. And please, if any of you have questions, drop them in the chat and we're happy to answer them. My question for you is just kind of one of those, where you sit and daydream about how perfect life could be. If you had one wish for how nursing education could change, what would it be? I would love to hear what you guys see as a needed change in nursing education. So if you had one wish for nursing education and how it should change, what would it be?
What would you like, Maria? I'm going to let you answer that question.
I think I don't want to get emotional. It kind of makes me emotional because of all the things that have happened just in the past couple of days with with assassinations and all the ugliness that we see. I haven't been watching the news very much, and I just started watching it again yesterday. And of course, we have some terrible things happen. I think my wish for nursing would be that we would treat one another the way that we treat our patients. We advocate for our patients. We treat our patients with respect. We go above and beyond for our patients. And then we can turn right around and say something ugly to one of our colleagues or about our colleagues, or we're tired and run down and we don't want students. I wish that we could be an example for the whole world, honestly. The world sees nursing as as the most honest profession. I would love for them to see us as the most caring and compassionate profession too. And that would really be my wish. What about you,
You know
Keith?
what? I probably I'll beat my dead horse, but you know what? I would just love to see the culture of nursing education put first things first, which is preparing for practice. And just if we just begin to make that mental shift, if we change the way we think about nursing education, that yes, the NCLEX is this unspoken elephant in the room that's always there. But if we as nurse educators are saying, okay, yeah, the NCLEX is out there, but I'm going to change the way I think. My primary purpose is to prepare my students for real world practice, and I will do whatever it takes to do that. I'm going to be difficult. I'm going to be challenging. I will use more rigorous unfolding case studies and active learning, though our students resist it, because I'm preparing them for practice. And I would love, before I kind of fade away in my journey, as I'm getting old, Maria, I'm gray, I'm tired, and I'm weary after almost 14 years of beating this drum and taking Benner. I'm just an advocate of Benner and Tanner. I'm not here to promote it's not about Keith RN. It's never been about Keith RN. I'm just Keith, and I'm an RN. And you know what? I just want to see us really see that nurses, like you said, Maria, they make a difference. And a nurse who does it with the heart, which is the art of nursing, the HEART, we can't lose that. And we're at danger of losing that. And so I want to see us reculturate that professional identity, the caring, and that foundation of what our profession didn't just begin with Nightingale. It began as a ministry of the early Christian church 2,000 years ago, caring for the sick because people have value. They're created in the image of God. Therefore, as God cares for us, we care for others. That's nursing, and that foundation is timeless, and we're at risk of losing it in a postmodern culture that doesn't embrace or doesn't see those values as relevant or as something that is that's optional. So, anyways.
Well, I think saying that in order to think like a nurse, you have to care like a nurse sums that up. You have to care about people, and you have to care about what you're doing.
And our students need to be doing that,
Taking
Maria.
care of
And we need to
people
hold them
in
to
order
that
to
standard.
right, in order to think like a nurse, because if you don't care, then you're going to miss things. You are the nurse that's going to have that failure to rescue because you're not looking for things. So that saying really does tie it up, that in order to think like a nurse, you have to care like a nurse. And I think that's really what we're about. We want students to think like a nurse, and we want students to care like a nurse.
And that's the foundation of Tanner's clinical judgment model. That was one of her assumptions of clinical judgment that came out. Her first step of noticing, Maria, is that a nurse is what they bring. Their caring, engagement, compassion influences what they notice. So when you're not caring, if you're not engaged, if you're burned out, just be honest. When I was burned out in the ER, I didn't care and I didn't notice at the same level. And our students who are task-oriented are the same way. And so we need to kind of recognize that connection. And let's bring back the heart as the art of nursing once again. And so,
yes. And Nicolette just said, my wish, students would realize that patients are people, not tasks. Amen. I think that's a great way to sum it up, Nicolette. And that's a great way for us to end. I want to say thank you again to everyone. This was a great conversation. We want to continue to have conversations like this. We want to be an outlet for you, but also hopefully provide you with some solutions. So thank you all. We hope to see you again next month. Keith, I'll give you the last word.
I just want to say, I just want to encourage you all that you're making a difference. I think that many of us as educators, we don't value what we do because our students don't value us. Our administration sometimes doesn't value what we do. But I want us to just step back and recognize that what you're doing has eternal significance as you pour into the next generation of professional nurses. And so I just want to encourage you to stay true to your why you are a nurse educator, and don't let anyone or anything steal your joy, your passion, your purpose, and what you're doing in nursing education for such a time as this, because you are needed. And I just want to say, don't allow the things that want to drag you to a different conclusion. Be a quieted voice, and may the power of your passion and purpose just reignite that flame. That's my heart, is to just kind of make it, just to kind of put some gas on that fire and make it easier to teach, save you some time, and just encourage you. So, that's why we're here. That's why we're having this conversation, is really to encourage and challenge and provoke needed change. And Keith RN will be a part of that, and to strengthen practice readiness, improving patient outcomes, saving human life. I mean, what's more important than that, Maria? So let's be that educator, and for such a time as this. And thank you again for all you're doing. So with that, I'll pass.
All right. Thanks, everyone. Have a good night.